If you really want to master the CBC, this video is a good place to start. I'll be covering 7 common CBC cases, and it's likely that one of these will closely match your own situation. If you don't understand a concept, I've linked a bunch of videos in the description. Let's go. And if you like this format, please leave me a comment and I'll do it again. Case 1 is a 30-year-old woman who got her labs done online. She feels well and her only history is that of heavy menstrual cycles. Of all the red numbers, what's the first one that you should look at? Which one is most important? The hemoglobin. Remember, hemoglobin is the protein that carries oxygen. Less hemoglobin equals less ability to carry oxygen. All the other red blood cell index abnormalities, including hematocrit, MCV, and RDW, will follow hemoglobin. Her hemoglobin is moderately low at 10.3 grams per deciliter. For a woman, anything lower than 12 is anemia. Note the red blood cell count is also low. This is used to diagnose anemia also, but let's use hemoglobin, and we're going to move on from that. The hematocrit is roughly the hemoglobin times 3, so 31.8% is in the ballpark of where we expect to be. The MCV is low, which indicates small hemoglobin and iron deficient red blood cells. The RDW is elevated because of the MCV change and the poor bone marrow quality control. The platelet counts are elevated because red blood cells and platelets are made from the same precursor cell. The signal to generate more red blood cells in the setting of anemia also generates more platelets, even though more platelets aren't needed. Now let's go to the iron studies: ferritin, transferrin saturation, and total iron binding capacity. Ferritin is the protein that stores iron. Low ferritin means low iron. You could literally actually stop here and don't even need the TSAT or the TIBC, but for educational purposes, I included them. The TSAT is only 10%, which is low. Normal is about 30%. Total iron binding capacity is also high. These are just 2 different ways of looking at the same empty protein. So transferrin has low iron cargo and therefore has high open space to carry cargo. There are lots of transferrin trucks driving around the highway empty, as it were. So what's the treatment here? Fix the heavy bleeding and start iron replacement, which is done with a high iron diet and supplements. And I of course have video links to ferritin, hemoglobin, hematocrit, and MCV in the description. In case 2, we have a 65-year-old man with type 2 diabetes, stage 3 chronic kidney disease, and obesity. So there's only 2 red numbers here, and which one is most important? That's right, the hemoglobin. He's moderately anemic with a hemoglobin of 10 and a hematocrit of 33. The MCV is normal. Since iron deficiency is the most common cause of anemia, the iron studies ferritin, transferrin saturation, and total iron binding capacity were checked. Ferritin is above 100, which indicates his body has normal iron stores. Transferrin saturation and total iron binding capacity are low normal. So there's subtlety here, but this is anemia of chronic disease, which happens because the chronic disease mafia freezes the iron supply chain. They shake down the bone marrow and they decrease EPO production by the kidneys themselves. The most common causes of anemia of chronic disease are metabolic diseases, including obesity, diabetes, heart disease, kidney disease, and COPD. If you need to fix your metabolic health and reverse anemia of chronic disease, I have a free weight loss checklist I've linked in the description as well. Case 3 is a 40-year-old African-American woman who had gastric bypass surgery 5 years ago and is getting routine labs done by her PCP. She feels fatigued. She's anemic with a hemoglobin of 11 and a hematocrit of 33. Her MCV is very high at 116 femtoliters. She's anemic with a high MCV. Based on that, what's the differential diagnosis? B12 and/or folate deficiency and alcohol-related anemia. She's not a heavy drinker, so let's look at the MMA and homocysteine levels to tell which one she has. Both the MMA and homocysteine levels are high, so the diagnosis is B12 deficiency. Remember, folate and B12 are necessary for the conversion of homocysteine to methionine, so both of them are necessary, but only B12 helps methylmalonyl-CoA mutase convert methylmalonyl-CoA to succinyl-CoA. So elevated MMA equals B12 deficiency. In addition, her folate level is normal, so folate deficiency is excluded based on that. She has the major risk factor of Roux-en-Y gastric bypass surgery. So B12 absorption, remember, is very complex, and B12 deficiency is almost always an absorption problem. Vegans can become B12 deficient too, right? But they can very easily overcome that deficiency by taking a very small supplement that helps them meet their 2.4 micrograms daily requirement. So often the first signal of B12 or folate deficiency is an elevated MCV, and this can happen, or it does happen, before the actual anemia develops. The other abnormality I just inserted here was benign ethnic neutropenia. This is common in people of African ancestry, so you can see her white blood cell count is low at 3,000 and her neutrophils are only 1,000. Having low neutrophils, especially below 1,000 per microliter, normally leaves people susceptible to infections. but not in benign ethnic neutropenia, which is felt to be protective against malaria. Neutrophils less than 500, though, in any person is an emergency. Case 4 is a 45-year-old man who drinks 4 beers daily and has done so for 15 years. He has a very poor diet, so what do you see? To start, he has a low hemoglobin and a high MCV again, aka macrocytic anemia, and this again narrows the differential to B12, folate, and alcohol-related anemia. His RDW is slightly high, folate is low, homocysteine is high, and MMA is normal. So what does he have? Folate deficiency, that's right, yeah. So his folate poor diet and alcohol use decrease folate absorption. And true folate deficiency is very rare in the era of food fortification. I mean, it's sprayed on everything. But alcoholics and the elderly are the 2 residual groups that still have high risk. So alcohol is causing his other problems as well that I put in here, including low neutrophils and low platelets. Alcohol is directly toxic to the bone marrow. The treatment here is alcohol cessation, a healthy diet, and then a temporary folate supplement. If this applies to you, I've linked good folate supplements in the description, and I've linked ones for prenatal prophylaxis as well. Case 5 is a 50-year-old man with cough, congestion, and body aches. His red blood cell count, hemoglobin, and hematocrit are all high, not low. His lymphocytes are high. His flu swab was positive, and that explains both things. You can watch the hematocrit video for more details, but influenza causes hypovolemia, aka lower plasma volume, which drives up the relative contribution of red blood cells, hemoglobin, and hematocrit to overall blood volume. They aren't elevated because the bone marrow is overproducing them. They're elevated because the plasma volume is low. The lymphocytes are elevated as a reminder that viruses are classically associated with increased lymphocytes. Voila, it all makes sense, yeah. It always all makes sense. Case number 6 is a 36-year-old lady with severe right flank pain, fevers, and burning with urination. So what do you see here? Her white blood cell count is very high at 17.9, and she has a neutrophilic predominance. It's mostly neutrophils. This is the classic finding in bacterial infections. She has pyelonephritis, which is a kidney infection. And in addition to the classic elevated white blood cell count with a predominance of neutrophils, she also has low lymphocytes and other subtle findings that I want to discuss. So look at her hemoglobin and hematocrit. The hemoglobin is red as normal, but the hematocrit is abnormal. If you look closer, you'll notice that both numbers are borderline. The hemoglobin of 12.3 falls right above the cutoff, and the hematocrit falls right below. The discrepancy is meaningless. You also note that the mean platelet volume is barely low, the RDW is elevated by a small margin, 0.2%, and the absolute monocyte number is high, while the percentage is read as normal. So I created all these trivial abnormalities to reiterate that not every red number on the CBC is important. My strategy here would be to recheck the CBC when this patient is well. You know, when things don't make sense, you need to recheck the lab and make sure you look into the details beyond just the red and the black. Hey, if you're enjoying this video, give me a thumbs up, I'd really appreciate it. Case number 7 is a 29-year-old female with severe cough for a month, history of asthma. What do you see here? Low RDW, high eosinophils, and high basophils. This case is a reminder of 2 things. Low RDW is not associated with any pathologic condition. It reflects excellent bone marrow quality control. Eosinophils and basophils are the predominant white blood cell responders to asthma, allergies, and eczema. Remember the eosinophil space force and basophil mall cobs? This patient received treatment with steroids, antihistamines, and inhalers. I hope this video was helpful for you. Let's connect on social media, and here's to understanding your labs and optimizing your health.